Good afternoon, and welcome to our first presentation of ANAwareness Week 2022. We're excited to welcome our diamond sponsor, The Ohio State University Wexner Medical Center, who has put together a fantastic series of presentations for the week. Today through Friday, we'll spend an hour each day with experts from their team sharing information and answering questions on various topics important to the AN community. I want to thank you all for your time and your efforts in putting this together. We're here today with Dr. Oliver Adunka, Dr. Joshua Palmer, Dr. Daniel Prevedello, and Dr. Yin Ren to discuss the multidisciplinary care of vestibular schwannoma patients. Before we get started, I want to go over how the presentation will work today. All of our attendees are muted, so you're only able to listen. If you have questions throughout the presentation, you'll see a Q&A button in your toolbar at the bottom of your screen. You can ask them there if you're in the webinar, or if you're watching on Facebook, you can just write your question in the comments section. There should be captions at the bottom of your screen. If you don't see them, click the captions button in your toolbar to activate them. If you're watching on Facebook, they should be active. You might have to activate them in your settings if you don't see them. We are recording this presentation and we'll house it on the ANAwareness Week page on the ANA website. It will be in the presentation section, and we'll also keep it on our Facebook page and add it to the video library on our website. There's lots of ways to get involved in Awareness Week this week. Visit our website at www.anausa.org/awareness, or you can just click the slider on the home page to find everything you need to know. Okay, doctors, I'm going to stop sharing my screen and turn my camera on. And we'll let you go ahead and introduce yourselves and let us know who you are. Dr. Adunka, you want to go first? Oh, you're muted.
Sorry, I was ready to go, but okay. My name is Oliver Adunka. I'm an ENT, so I'm a neurologist. I work at, again, Ohio State. I've been there for about 8 years. I work closely with Dr. Prevedello, who will introduce himself soon. As you know, my neurosurgical colleagues. Dr. Palmer will join here in a minute. He's the radiation oncologist. Yeah, just happy to be here. And I hope this is helpful for all the participants.
Thank you. Dr. Prevedello?
Yeah, so I'm Danny Prevadillo, one of the neurosurgeons here. I'm the director of the skull-based surgery here at the James and the Wexner Medical Center, and work very close with Dr. Ren, Dr. Adunka, and this is really who we are. We really, think that we have a very good program based on the fact that we have basically a union multidisciplinary work. We're not just, neurosurgeon and neurologist working together for taking care of patients with acoustic neuromas, vestibular schwannomas, but we have other disciplines that really are important. Like we have ophthalmology that work with us. We have, the facial reanimation team. We have radiation oncology with Dr. Palmer and others. And this is, I think, so who we are as a group. So I'm the neurosurgeon of the team. I'm not the only one. We also have Dr. Doug Hardesty. We have Dr. Razlonzer as the ones that that perform surgery on vestibular schwannomas as a team. So very proud of having a team and work together with several specialties.
Great, thank you. Dr. Ren, you want to go ahead?
Sure. So I'm Yin Ren. I'm one of the ENT otology neurologists at Ohio State, relatively new. I started at Ohio State last summer. I want to thank ANA for really putting this together. I think it will be a fantastic week of webinars, both for patients with acoustics or patients who are newly diagnosed or patients who are just interested in learning more about this. I think it's something that often, we as a team treat acoustics together. It's something that we work with each other on a daily basis. So I'm really glad that we start off the week with sort of this overview, how we approach this in a multidisciplinary way to best help our patients, to best achieve the best outcomes. And then we'll also have webinars that focus on hearing rehabilitation, which will be tomorrow with one of our audiologists, as well as facial reanimation, as Dr. Prevedello mentioned. So, we are here, but there are others that will join us later in the week with a facial plastic and reconstructive surgeon who work with, us on acoustic neuromas rehabilitation. We also have a webinar with one of our patients. We'll talk about her experiences. And then finally, we'll end the week with physical therapy, vestibular therapy, with two of our vestibular therapy specialists at Ohio State. So I think it'll be a great week, and thanks ANA again for organizing this.
Thank you. Thank you for joining us. Welcome, Dr. Palmer. Thank you for joining us. You want to go ahead and introduce yourself?
Of course. Thank you guys for the opportunity. It's great to be able to speak to everyone. So I'm Josh Palmer. I'm a radiation oncologist at Ohio State. My area of specialty is in brain tumors. And specifically, I work with the skull-based team here to treat people that have benign or malignant tumors of the skull base, and that would include the acoustic neuromas.
Okay. Well, I'll let you guys go ahead. I know you have some slides to share, so we can go ahead and get started with that. And then I'm watching the questions on both Facebook and on our webinar here, so we can get to those when you're through your presentation.
Perfect. So if it's okay with you guys, I'll probably
why don't you get started?
the screen.
Yeah, sure. Again, for the participants, I think we wanted to make this as interactive as possible, right? So thanks, Melissa, for checking the chat. So I think Josh will again just briefly kick us off with a few slides just to set the tone, and hopefully we can again have as interactive as possible kind of event here.
Sounds great.
Can everyone see the slides properly?
Yeah, perfect.
Perfect.
That looks great.
And so we'll go over some of the basics of how a radiation oncologist would evaluate someone who has a vestibular schwannoma, and then what we look at in terms of treatment options, because it's increasing in utility to be able to offer patients a number of different choices, and really is important to put the patient at the center of the decision-making process. And so just super critical, the surgeons know this very well. This is a very eloquent region to have a tumor, and this just highlights just how difficult it can be to go in and try to resect and remove these types of areas. It's a very eloquent region that requires someone with a lot of expertise. So our surgeons here have this expertise to be able to go in and expertly remove a tumor in a location like this that's surrounded by so many important blood vessels near the important areas of the brainstem and other cranial nerves. Typically, people, when they present with a tumor like this, will have some aspect of hearing loss. And so, having hearing loss on one side, as opposed to kind of a aging, which would typically affect both ears, that's a critical factor. So people will go to a physician to if they have some a hearing loss on one side. Ringing is another one. Headaches. Typically, these other symptoms of balance, facial nerve injuries, and numbness. That's for these larger tumors. Definitely should be seeking care if those happen. Things that will get tested, and you'll go over in the rest of the week with the other experts, is trying to identify how impacted is that hearing nerve or the acoustic nerve. And as a radiation oncologist, what we think about is how serviceable or how useful is this hearing, because that impacts for us how we'll treat those individuals. This is just showing some of the different types of hearing loss that can occur, and the ones we typically see with these tumor types is sensory neural hearing loss, the bottom left. And the cutoff that we'll use, or that I'll use to help guide treatment, is the levels 2 and 3. And so if a person can discriminate over 50% of the speech during the audiogram, and the tone is less than 50 decibels, typically we view that as good and serviceable hearing. If it is very difficult to discriminate speech and it's less than 50% on the exam, and then they have to turn that noise up extremely loud over 50 decibels, typically we view that as non-serviceable, and that typically will get a separate treatment algorithm. And so this is kind of what those tumors look like. A lot of different options here. This is from what I think is a very useful review article from 2021 from last year in the New England Journal of Medicine, showing what these acoustic tumors can look like, and then some of the other things that can mimic them. The grading scale that surgeons will use typically have different grades, and as they get higher, typically surgery is much more useful for those types of tumors. The very small grade 1s and 2s typically are amenable to radiation. So how do we decide? So gamma knife radiosurgery or single treatment radiosurgery is oftentimes a treatment of choice, especially for non-serviceable hearing. And that looks sort of like this. You'll have a radiation machine, either a linear accelerator, a gamma knife unit, or a cyberknife unit. They're all sort of tools that we'll use that will deliver a very similar treatment regimen to do it in one single treatment. The gamma knife radiosurgery is the one that's being shown in the bottom left. The Linac-based one is in the bottom right. Cyberknife is in the top right. They will all deliver a very highly conformal or a very tight dose fall off treated just to the disease. And the tumor gets a very good sort of ablative dose, and you can see how quickly that dose falls off, so that the areas of normal brain and areas that we think of as important to spare, which in the bottom left figure is that green, or excuse me, the pink area in the bone, which we refer to as the cochlea. We try to keep that out of that 20% line here. And so the more that we can do that, the better the patient's hearing will be post-treatment. And there's a large experience throughout the US. These are just the ones done initially with pioneers at the University of Pittsburgh that have done this quite a bit with gamma knife. What I'm highlighting here is we used to use a much higher dose. We found that dose is likely not necessary, and now we've sort of fallen on a dose that we think is best, which is the very bottom, 12.5 to 13 gray. Why did we do that? Because we found that it's very tolerable and has very low risk of causing injury to nerves that are near there. So if you remember back to that initial anatomy slide, there's a nerve that sits very close to where we're treating, and you can see weakness of the muscles in the face, sometimes from treatment. You can also see this from surgery. That was a much more prominent symptom when we used higher doses. It's very uncommon now if we use lower doses. But you can see here that we can actually see hearing loss after gamma knife radiosurgery. We have to keep a very low dose to the actual hearing apparatus if we're going to try to use gamma knife in someone who can hear. So oftentimes when I see someone in clinic and they have serviceable or good measurable hearing, typically I'll stray away from this unless the tumor is not very near the rest of the hearing apparatus, because you can see that dose really does matter, that the closer the tumor gets to that hearing area, the cochlea, the more likely we can decrease the hearing with just doing the treatment. So it's important that we weigh kind of our treatment options based on its proximity. And what that's showing here is the tumor can be very close to this hearing apparatus. We also worry about things like these areas here that can lead to a person having more dizziness or imbalance or falls if it's near the semicircular canals. The gamma knife and hearing preservation rates are typically somewhere between 50 and 70%. We hope to be doing better than that these days with other regimens. And then this is just highlighting there's excellent overall control. Now, we also have in our arm in some treatment regimens a fractionated radiation treatment, and that takes advantage of the fact that when you take a large single dose and break it up over tinier doses, little packets over longer periods, you take advantage of normal body healing in between. That's sort of the nature of how radiation biology will work for tumors and normal tissue. And we're able to deliver a dose that should control tumor at a much lower toxicity rate. And so for those individuals that have useful or serviceable hearing, this is a good option for those individuals that can help to preserve that hearing, decrease the rates at which we see injury to the nerves surrounding it, and is an alternative to gamma knife radiosurgery. And so that's been published on over the years, both in Germany and in the United States. We've shown that compared to gamma knife radiosurgery, the control rates are excellent, somewhere between 95 and 99% at 10 years. And you see that the rates at which we cause injury are much less. And what I'm highlighting here is that if you were to take a similar dose to what's used in gamma knife, or what some individuals will use around the US, versus the lower hypofractionated dose, the 46.8 gray dose, which is what I would consider as a good standard for individuals that have good, useful hearing, the hearing preservation rates are actually much better. So what you're seeing is that radiation delivered at either a higher dose or with gamma knife radiosurgery, if it's near that hearing apparatus, you can see a nice steep decline in their hearing because of treatment. What we hope to show and use and see in our patients is sort of a natural decline in hearing with age, or sort of a decline that isn't steepened by our therapy. And we think that by using this more fractionated course at the lower dose here, the one on the right, we see a really high hearing preservation rate at 10 years, which we hope to continue to see in these individuals. This is just highlighting what that looks like. You can see it to the untrained eye. This looks almost identical to the gamma knife radiosurgery treatments. The nice thing is that we essentially take that therapy, but then fractionate it out over a longer period of time. And then this is just highlighting same thing that we showed with gamma knife radiosurgery. If we can really push down that dose to the hearing apparatus, the cochlea, those individuals have an even better hearing preservation rate than those individuals out 3, 4, 5 years if you aren't able to spare it quite as well. And then these are some select other series, both from the German group at the bottom, but also which also have a very large number of patients. They were the largest in the world so far. And then the Japanese groups also highlighting excellent rates of control with this regimen. So it's essentially this concept of de-escalation. Can we still control the tumor, but get people better outcomes for toxicity? We're able to show that in the gamma knife radiosurgery literature. We're also seeing that in this fractionated treatment, likely over-treating people going to that higher dose don't need it. And so this is just highlighting a lot of the different options people have. The gamma knife radiosurgery, like I said, is probably best for those individuals that have larger tumors, can't be removed fully, and don't have hearing. Using that fractionated dose regimen is probably best for those individuals that do have hearing. And then people have tried fractionated proton treatment. Unfortunately, that's the outcomes with that. We're using the higher dose, and those outcomes did not look very good. So that's at the moment probably not the best first choice, but it's still under study around the world. And this is just highlighting some of those that I mentioned, that looking at the Harvard experience and others that have protons around the US and in Europe, that the overall rates of control and toxicity are probably in the same range that of probably 10, 15 years ago when we were using IMRT. So not as good as what we're seeing in our current radiation regimen. So probably not the best first choice, but still something to think about. And this is just comparing all of those regimens here. Ideally, what you want is to go to a center with someone who has a large experience to help you choose between the different regimens, because there are so many options, to make certain you're making one that's very personalized to you as an individual. Trying to limit the actual complications that we see, and also follow along, because we do see, and sometimes can worry patients, is this phenomenon known as pseudoprogression, just to highlight that it is something we do see. It's not super rare, and it does improve with time. We just have to make certain patients don't get overly anxious when they see this on the imaging. And so some of the pearls, how we choose between different regimens, I think the key is you want a really strong team of surgeons, audiologists, and radiation oncologists to be able to help you choose between all the different options. With that, I would want to open up to any questions.
Yeah, thanks, Josh. And I think, it really boils down to the team, right? And I wanted to highlight that. And maybe we already have some questions in the chat, right?
Yes,
and,
I saw that.
There's some excellent ones. So We'll get to those in a second. I think it's really critical for us to communicate that it's important to have these discussions, and these happen, amongst all of us, right? If Dr. Wren has a tumor and takes it to Dr. Prevedello and then ultimately Dr. Palmer, right? It's important that the patient gets all these kind of opinions or their expertise, related to the tumor. Now, oftentimes, there's some tumors that, when they're 4 centimeter large, right? Obviously, that's a surgical case, but as MRIs are on every street corner these days, we're just detecting a lot of smaller tumors, and it's important to recognize that some of these don't need to be treated, right? That's another fact of today. I think Josh, a few questions to you, right, and that go along with some of the questions in the chat here.
Yeah, Oliver, if I could just mention before you go to the question. I just want to reemphasize that based on all these different nuances, is that we basically, the way I see is that we customize what is the best for the patient based on the details of what that patient brings, right? So there's, like Josh was mentioning, sometimes the tumor is close to cochlea, so maybe something else is better. Sometimes there's a small tumor, but the patient has a lot of dizziness and vertigo and is suffering with that. So maybe radiation is not the best option. Taking the tumor will be better. So we really talk about what is the best for that patient, really in a customized way, because what is the best solution for one person may not be the best for another. And the best way to achieve that is with this multidisciplinary group with different expertise, where we go back and forth and to try to get the best really solution for the problem of that specific person. So that's what I want to say.
No, it's a great point. It's a great point, Danny. So I think let's tackle some of these questions. And Josh, most of these are for you, right? So
before we get started with that, can I have Dr. Palmer, can you stop sharing your screen? And then that way our faces will be a little bigger. That helps with people who want to read lips. So, thank you for doing that.
Let's start from the top here. So one question was, does radiation actually shrink the tumor or just stop it from growing further? Do you want to?
Of course, yeah. I think that comes up a lot when we're discussing, especially a consultation, but also in follow-up, what to expect in terms of tumor changes post-treatment. A lot of times we look at it like this, that fast-growing tumors or malignant tumors typically will shrink quickly, but benign tumors, slower-growing disease like these acoustic schwannomas, typically won't change dramatically. So what we deem as a success is when we're using radiation, can be no growth ever again in life. And so what we're trying to attempt to get is local control that is durable for many years, so that it doesn't require any, or doesn't grow and press on new areas or cause symptoms. But there are situations where it will grow, and that's where it's key to understand that a pseudoprogression, we have to try to differentiate that from an actual true tumor growth, because those individuals that have pseudoprogression, that's usually a phenomenon related to a lot of quick tumor death. And so it necroses in the center, becomes a sort of a liquefied area in the center, and then it'll eventually shrink and get smaller. Those individuals might actually see shrinkage. And about a quarter of people over time can see shrinkage in their disease. But I would say the most common phenomenon is stability. So the majority of patients will see no growth.
And maybe my 2 cents on this topic. And one of the questions was, what is pseudoprogression? So pseudoprogression would be what Dr. Palmer just explained, that the tumor basically swells for a certain period of time. And that can be up to, in my experience, up to 2-3 years. Correct, Josh?
That's right.
Yeah. So certainly important to distinguish pseudoprogression from actual, progression due to tumor cells dividing, right, or continue to divide, right? I think that's what we're looking at. I think one thing that I wanted to comment on is your rates of tumor control. And one of it's difficult because a lot, when we use radiation for the Ohio State is mostly for tumors that do exhibit growth, right? But that's not necessarily what is done all over the world, right? So there's a lot, especially over in Europe and other. Do you have any comments on that?
In terms of like the number or like the percentage of control?
Yeah, I think, you know, because the number that you put on your slide is like 97, 98% of tumor are controlled by radiosurgery.
Yeah, I think the real number is probably lower than that. I think
Right.
in the series that we used, it was sort of a cherry picked of just those individuals that got fractionated treatment. I think if you're looking at a population perspective and those individuals that come with lots of different tumors that are of different sizes and treated with gamma knife or fractionated treatment, it's usually somewhere on the order of 90%. We think of it as somewhere between 85 and 95 is probably the range that most individuals can think about for control at 10 years, hopefully durable for that next 15, up to 15 to 20 years. And it does decrease with time. And so the challenge is when we use these types of numbers, it's something that we have to think about as an individualized kind of assessment, because smaller tumors are more likely to be controlled than larger ones. Larger tumors tend to, if they are going to grow again, but it could be 10 to 15 years later. So that's one of those things that's also critical for people to know, is that some people in different areas of the US or world can be told, hey, you don't need to follow this anymore. That's probably not always true. That when you get radiation or get surgery, a lot of times you could decrease the rate at which you get imaging or see the physician. But I would argue that it's important that you continue to follow with your team indefinitely, because you can see some people get tumor recurrences many years, if not decades later. And it's important that also from a radiation oncologist perspective, is that sometimes we can see injury from radiation many years or decades later, or some sort of manifestation of treatment differences or changes or injury that can happen 10 to 20 years after the therapy. So we do want to continue to follow up on those individuals to be able to see that and help with it.
Dr. Palmer, there's a question on our Facebook page quickly about recurrence like that. So if somebody had gamma knife early and then they do have regrowth later, can they have gamma knife again, or can they have any kind of radiation again? Or is that point, do we look at different options for treatment?
It's a good question. I think a lot of it depends, like Dr. Prevedello was mentioning, it takes sort of a team effort to try to determine what that right next step is for everybody. And it's super hard. Like it's hard to necessarily say this is what you do next without understanding sort of time between treatment. What does the MRI look like? What's the size look like? What's the age? What's the comorbidity? There's so many factors. But what I would say is that typically if a person's had gamma knife radiosurgery and it's been several years since that radiation can feasibly still be done. It just might not be that right next choice. Oftentimes, if it's failed radiosurgery the first time, you might want to strongly consider other options like a surgical intervention to gain better control, or some combination. But I think typically I wouldn't say that you can't give radiation again because it's been given the first time. It just may not be the right choice, because if it's failed it may be for some reason. Maybe it's not going to respond well. It needs additional local control with a different mechanism. And so I think those are the types of situations where it's super important you see a really well developed team that does this all the time, because that's not a situation I would want someone who doesn't see a lot of acoustic neuromas dealing with, because you should see someone like Dr. Adunka, Dr. Wren, Dr. Prevedello to decide maybe this is the right chance for surgery.
Yeah, and if I could, I would just continue one thought that a lot of people ask, how about after radiation, if the tumor grows, and then when we do surgery, what is the aspect? And as a general answer, it does look more difficult, causing some level of inflammation and adherence there, but doesn't mean we cannot resect the whole tumor. I remember not too long ago, there was a patient who had a gamma knife procedure that was done elsewhere and came to us with a progression of the tumor 10 years later. And our decision was to proceed with surgery and take it out. At that point, it was causing some extra compression on the brainstem. And I did the surgery, Dr. Duncan, we were able to get the whole tumor out and preserve the facial nerve. So it's not necessarily when radiation was done in the past that cannot be achieved surgically. Of course, it's more challenging, it's more difficult for us, but it's still possible.
Okay.
Yeah, so maybe we can tackle a few. We want to tackle all these questions.
Yeah.
Those are great questions. I'm just looking through the Q&A, right? So I think
there's a couple more about that pseudo progression, and
yeah,
I had
maybe.
two about how do you distinguish that pseudo progression from actual tumor growth. And somebody else asked if there is that swelling, do you treat that with steroids or do you just let it settle down?
That's a great question. So usually what we'll do is if it's an asymptomatic change, we'll typically continue to follow it with close interval imaging and not intervene yet. Partially because many of these people will have these changes that don't manifest any symptoms.
Mhm.
And so if it's just simply an imaging change, oftentimes we'll just monitor that over a longer period of time until it stabilizes or improves. If there are symptoms associated with the change, that's typically the marker that we'll use to begin some sort of medical therapy. So steroids, boswellia, some sort of anti-inflammatory medication that will help to resolve some of the symptoms. And then if it gets significant, so they say it swells to the point and does not respond to medical therapy, that's a situation that may need the surgeons to help with, to either drain the cyst or remove the tumor or do something surgically to help improve those symptoms.
Okay.
Great. Can I answer one question, Melissa, real quick?
Yes, go ahead, please.
So Maggie asked here in the chat, for someone with appreciable oscillopsia in disequilibrium, and oscillopsia basically is exactly that, it's a lack of balance, really.
Mhm.
What are the chances of that improving post-radiation? Maybe, and I wanted to get Dr. Wren involved in this question. I have some thoughts, and maybe Josh can add to here, but it's certainly something from an ENT perspective, we do see a lot, right? We do see a lot of balance issues with these tumors, obviously. So Ian, would you mind tackling?
Sure. Yeah, I think, there's sort of two ways to kind of address this. In general, I feel like if patients with tumors have a lot of disequilibrium, probably more severe than oscillopsia, but they fall, if they have episodes of vertigo, so severe room spinning that sort of comes on suddenly without a clear trigger, that could potentially be dangerous, right? If they're, doing their normal daily lives, they're driving, they get these vertigo attacks. We generally feel like that surgery would be a better option for helping with those vestibular symptoms. But that being said, with surgery, right, doesn't matter what type of surgery, for the most part, we have to take the vestibular nerve as part of that resection. And as a result, they do not have vestibular function on that surgery side. So we counsel patients is even after surgery, the balance is not normal. It can be very close to normal, but it takes work, with vestibular physical therapy. And often patients would still complain, their vertigo symptoms and some of these disequilibrium pre-op would improve, but they can still feel at times imbalanced if they're tired, if they're in an unfamiliar environment, or if they're, the ground is uneven. So certainly there's a compensation that patients go through with vestibular physical therapy. But if they present with severe vertigo symptoms, radiation sometimes may not be the best to alleviate those.
Would you agree, Josh?
I agree with that. I think in our experience and just in general, those are very difficult symptoms to palliate with radiation. Typically, the way that I would look at how radiation typically functions is we can stop growth, but symptomatic improvement from, say, a large tumor that's causing pressure on the brainstem or other areas that are leading to these types of symptoms, that's usually not something we see a lot of symptomatic improvement with. So a lot of times when someone's symptomatic in that way, so it's not just hearing loss or tinnitus, if it's other associated imbalance or brainstem compression that's causing problems, or facial nerve injury, then that's something that would likely require a surgical intervention. That would more rapidly improve symptoms, because again, radiation is one of those things that works really slowly in terms of overall benefit to the symptoms. So it's not something that would get better quickly. It's usually not something that gets better often with just simply radiation. The radiation's intent is really to stop growth. So if you're seeing someone with just a slow growing acoustic tumor and you want to prevent symptoms, so someone who's say, in their 60s, 70s, 80s, and you want to prevent these symptoms, limit morbidity of the surgery, and it's simply growing, then that's something I think is very reasonable for radiation. But someone who has a lot of symptoms from a tumor, I think radiation is probably not the best first choice, given its unreliability of actually improving the symptoms, especially quickly. That's something I think surgery does so much better.
Great.
That's I think related was the stuffiness question we had, right?
Yes. Yeah, there was a couple about symptoms. One was how about loss of stuffiness with AN surgery or radiation, like that clogged feeling that many patients complain about.
Right. That's, I will say from my perspective, and everyone else please chime in, it's a tough one, right? A lot of times the stuffiness, what we call oral fullness, is a sign of hearing loss. And we see that with or without acoustic tumors, right? So a lot of folks who had sudden hearing loss, which again has, usually there's no acoustic tumor behind those cases, have this feeling that, they come to Dr. Wren and I, and they say, hey, there's some wax in my ear canal, take it out. And we take a look and it's completely clear, right? So it's something that's hard to alleviate, frankly. And if you came to us, we would probably not make you big. We would probably set the expectations low on our ability to resolve this, either with surgery or radiation for that matter. Would you agree, Ian?
Yeah, absolutely. I think, your point about sort of having a frank discussion, right? So I think, it's a long-term relationship. There are many symptoms that may get better with treatment. And I think we always have a very honest discussion to set the expectation. There's a patient with a large tumor that may be completely asymptomatic, but we'd recommend treatment because, it would have effects on compressing the brainstem. And then there are patients with very small tumors who are extremely symptomatic, but surgery may be good, or radiation may be good in treating some of those symptoms, but does not always address all the symptoms. So I think with the oral fullness, exactly, it's most likely from this asymmetric hearing loss. But with all of these treatment options, we don't actually improve hearing. So there's no treatment, at least right now, that will for sure give your hearing back. And in fact, if most of the treatments or observation, your hearing will decline over time in the next 5, 10, 15 years, and that fullness may get worse. And same with tinnitus. Tinnitus is something that we don't have a great treatment for, and sometimes with hearing improvement, the tinnitus goes better, sometimes it doesn't. So I think just having a good discussion with your provider about what are the goals and what are the important priorities for treatment is extremely important.
Yeah, maybe there's one question that sort of caught my eye here. That's Nicole, who's 24 and had a large tumor. There's still a 2 centimeter tumor remnant left. And, she's 24 again. So anyways, she had some facial weakness, it seems like, but that's thankfully recovered now. So yeah, Josh, any thoughts, or Danny, really, both of you guys, I'd like both of your opinions on.
Yeah, the way I see it at 24, I think it's several things needs to be taken into consideration here. What was the original approach that the surgeons did? If it was a translabyrinthine, if it was a retrosig, or sounds like it will be one of those 2 options because of the size of the tumor. But in a 24-year-old, perhaps the best option is to observe this tumor. Sometimes when we devascularize most of the tumor and debulk these tumors, they collapse and they get smaller. And it could be that it stays stable without growth for a long time. So before throwing radiation on a 24-year-old, I think these are and the other information is to look at pathology, see if there was any sign of aggressiveness. But if we're dealing with a typical schwannoma, there's a opportunity here for observation, repeat imaging, make sure it's not growing. And if it grows, then you make a decision to go back with a second surgery versus doing radiation that we, in general, as a group, we try to avoid in a young person, like particularly 24. So I'll let Josh compliment.
Yeah, that's exactly right. So there's a lot of great data. There's a lot of great series that have been published on observation and how that looks for someone with a benign schwannoma or just benign tumors in general. They don't always grow linearly. And so different people's tumors can grow differently throughout their lives. And for some individuals, it'll grow for some period, but then plateau and then grow again. And it depends on sort of the different changes that are occurring in your life. And so it's possible that for a woman younger, that this could not grow for a period of time, but then could grow later in their life. And so I think I would take the opportunity to initially see what the growth kinetics look like now that it's so debulked. Now that you have such a small area, watching to see how that changes over time, and following that and observing that with someone relatively in short interval, to make sure you don't miss an opportunity where it grows over a period of a few years. And if it doesn't grow for a very long time, you're just buying yourself a lot of time. Maybe 5 years, 10 years, who knows, 20 years before it actually grows in any meaningful way, and trying to define what that means for that individual. That's always somewhat difficult. Usually it's hard to predict what that symptom is going to look like as you're observing, but typically we don't want it to grow and start pressing on the brainstem or something in the brain. We don't want it to be impacting your hearing. So I think as you observe, you should also be seeing your audiologist and getting hearing exams, because you don't want to follow it so long that you lose your hearing. Typically we want to follow, and then if it's starting to impact your hearing in a meaningful way, that can also be a time period you'd want to intervene to try to preserve hearing. Where there have been patients that Dr. Prevedello and I and Dr. Duncan and I have treated over the years that are young in their 20s, that we've done something similar to what the description here, where they'll be followed if there's growth. Oftentimes, if a person's got serviceable hearing, meaning useful hearing on the audiology exam, those individuals I probably wouldn't gamma knife. That's a typical scenario that is done a lot in Europe and certain areas in the U.S. I'd probably fractionate that treatment, try to preserve the hearing as best we can, get a shallow of a hearing curve as we can get for you, so that way you preserve it for a very, very long time, but also gain control. But I'd probably only do that if during observation there's a meaningful growth, or during that observation period there's a meaningful change in hearing on the audiology exam. But that's typically how we would address those sort of situations, trying not to treat someone so young for the risks that radiation can have later in your life.
Well, it really illustrates, the critical nature of these team discussions, right? To really have everyone on board. And, when people call me with acoustic tumors that are on the other side of the country, or in different countries for that matter, I tell them, just make sure you have a team, right? Just make sure there's a team, and the team has a track record, and they all talk to each other. And that's really sort of critical, right? But it also, this case, Nicole's case also underlines, what you just mentioned or started to mention, Josh, is, the role of age with radiation, right? And how the neurotology community usually thinks about it is 65 and above with a growing tumor, right? And older, we consider radiation. 65 and below, we usually drag our feet, right? So you started to answer that, but maybe you can add some more detail here.
Yeah, I think as a radiation oncologist, we're probably a little bit more aggressive with the age. Usually we set it at 50. And so I've attended some of the tumor boards, even in Germany, we sort of set the same age for whatever reason. I think typically, if you want to get super detailed about that, you can also try to look at sort of an actuarial curves of where your life expectancy lies. Typically, what we're trying to do is, if your life expectancy is measured in probably 25 years or more, then it's probably not the best first choice to radiate if you have other good options that can give you equal outcomes, because the risk of some secondary tumor or injury can potentially outweigh the actual benefits that you're getting. And so, like, oftentimes, in the US at least, the setting it at 50 to 60 can still work for many individuals with life expectancies in the mid 70s to 80s. But if you're a very healthy, have a long family history of living into the 90s or hundreds, then I would set that age limit much higher. But it always just depends on the clinical scenario as well, and sort of that. A lot of times people will have patient-related preferences. So, like, if you're very strongly or adamantly against radiation for whatever reason, or adamantly against the surgery for whatever reason, those also need to pay a lot of close attention to that particular person's wishes and goals in their care, because that also can drive the decision. But I think the age may vary depending on who you ask, but at least the way I look at it is, if you're over 50, it's very reasonable to think about it. But I agree with you that the closer you get to that 60, 65, it's much, much simpler to say the risk that to you is going to be less than 1%. I think if you're in your 50s to 60s, I think the risk is less than 5% that you'll succumb to some late effect. But I think is a reasonable thing to do. Younger than 50, I think it's very hard to argue that if you have good other options, that radiation should be done, only because the life expectancy of an individual in their 20s, 30s, and 40s, it's likely that the risk is somewhere around 10% or more that you'll have some radiation effect. So it's becoming less reasonable to do it if you have good surgical options that can cure you.
Yeah, and maybe there are some questions. Martha says she has a 1 centimeter tumor. Is that one a good one to treat with gamma knife? Hearing loss is her symptom, and I would argue it all depends, right? I mean, there's so many other variables to consider that it's hard to, I mean, in theory, yes, we would like to see growth before we treat the tumor, right? We'd like to see a growing tumor. But, if your hearing loss is very mild, we would offer you potentially surgery, right? As a middle fossa approach, where we can preserve that. Or if it's something you don't want, right, then certainly radiation would be an option. If you already lost all your hearing, right, then we often argue, then you might as well just take the tumor out, right, and sort of be done with it. But again, it's such a, you think of acoustic tumors, and there's only so many symptoms you can have, but the combination and your age and tumor growth and the biology and cystic versus non-cystic tumors, right, those are all things that are relevant for us, and in making a decision. So I think oftentimes it really boils down to some of the details, like with everything else in life. That's at least what I tell my kids. But
Dr. Adunka, there's a question on the chat, and then another one on the Facebook page about and maybe Dr. Palmer, about the fractionated radiotherapy, and if the studies that have been done that say that it can potentially lessen hearing loss at a deep drop, do those benefits extend to the facial nerve as well, or has that not been studied? And then there was someone else that asked about trigeminal neuralgia and how that can be affected by fractionated.
Good question. So yes, both the Germans and a number of places in the US have looked at other cranial nerve tumors and the effects of fractionation. So this comes in handy when we treat the olfactory nerve as well. So we think that sparing smell for the olfactory tumors that are benign, fractionated should be better. We think of the same for facial nerves. So any nerve, cranial nerve that has a benign tumor, whether it's facial nerve, the eighth nerve, the acoustic nerve, or the smelling nerve for one, all of these theoretically can benefit from fractionation to spare injury. Because what you can think about is when we do the treatment in a more intense fashion, you increase the potential for some sort of radiation injury with the treatment. And so the fractionation benefits us in a from a radiobiologic perspective of injuring less of the nerve we're treating to preserve the function of the nerve while still controlling the tumor that essentially surrounds it. And so it's kind of like preferentially trying not to harm something that's in the field of the radiation treatment that's being treated. And so there are experiences going after other cranial nerves. That also includes things like 9th, 10th, and 11th cranial nerve schwannomas. These are much more rare than an 8th cranial nerve, but we do have experiences fractionating them, and it's the outcomes are excellent.
Yeah, I think one interesting question that also caught my eye here is a person in the chat who has a 3 centimeter tumor remaining after surgery, right?
Yes.
That remnant is causing trigeminal neuralgia, and his or her physicians are recommending Gamma knife. I don't know. Frankly, I would be hesitant of that, right? Number one, I mean, my personal opinion would be 3 centimeters, a little too large, right? Not maybe too large to radiate, but the biology of the radiation will change with that volume. Plus, Josh, is based on what you said earlier, right? I mean, we wouldn't necessarily expect trigeminal neuralgia to be improved, right?
Because you're not really, so although giving Gamma knife can be a treatment for trigeminal neuralgia, I think it's important to differentiate trigeminal neuralgia from a tumor pressing on a nerve versus trigeminal neuralgia from the actual nerve. What we think of as either being pressed on by the vasculature around it or like actually being injured in a person who has sort of a tic douloureux, like not from the external compression of a tumor. When we do radiosurgery with Gamma knife, again, it's a very low dose. When we do trigeminal neuralgia treatment and it actually intend to help improve the trigeminal neuralgia, it's a extremely high dose. And it's to the actual nerve itself with an intention to try to essentially stop the nerve's function so it stops hurting. The likely, and this is just, I guess, in my opinion, the likely reason that a tumor like an acoustic is causing it is from an external compression that would get better by removing that compression. And so like seeking an opinion of an additional, several surgeons to confirm whether that is removable or not in a safe fashion is probably the right choice to see if that can be externally removed off of the nerve. That would likely be the most helpful symptomatic improvement, because even if we did say use Gamma knife, likely in all likelihood the tumor would be very similar in size, could potentially get worse like we mentioned, so that could worsen the symptoms that are underlying, but really I would argue probably won't improve that type of symptom, because we're not really going to see a lot of people with a significant shrinkage after radiation to try to improve that type of symptom. That's the type of symptom that would likely be benefited from a surgical debulking or removal.
Yeah. Yin, any other thoughts? I mean,
yeah, I mean, I totally agree. I think, the issue also is when you radiate something at 3 centimeters, the issue of swelling post-radiation, I think it could be potentially problematic, both from a symptom, but also, we don't know where this 3 centimeter tumor is. We'd have to look at the scans to look at that. But I think I agree with everything that's been said. Compression by the tumor, certainly relieving that through surgery would probably be more effective.
Yeah, I think Larissa had a nice, a nice write-up of her case here. So looks like Larissa's pretty young, right? It was 4.8 centimeters, so 48 millimeter tumor. When it was 22, and he left partial to preserve my facial nerve, a month ago. So I hope you're doing okay, Larissa. So thanks for joining today. Certainly, probably a big surgery, and you're still recovering. Looks like your facial nerve is working, so it seems like that was the right thing to do. Depends on how much tumor is left, right? So usually, if we leave tumor, we obviously want to minimize that, right? So there are three categories that we usually talk about when we talk about the degree of resection, right? The gross total resection is basically that we basically have removed all the tumor, right? We haven't seen, there's nothing left that we can see. And then a subtotal resection, on the other hand, is when we leave a pretty substantial chunk of tumor left, in there. And then a near total resection basically denotes that we pretty much took most of the tumor out and left a small little sliver on the facial nerve. And I think you'll see that. I think generally speaking, we try to do a gross total removal of the tumor, right? We try to take all the tumor out every time, right? I don't know, Danny, any thoughts? I mean, that's
yeah, I agree with you.
Yeah. So anytime we leave tumor, really the only reason for us to leave tumor is to preserve the facial nerve. That that last bit of tumor that's usually stuck on the facial nerve. We call it the area of usually the porus, is when that acoustic canal starts from the cranial cavity. That's usually, if we have to leave tumor, that's usually where it's extremely stuck. We've seen in other areas, obviously, but that's typically the scenario. So, and again, we don't like to. We like you to be done with it, right? We like for you to send you out the door and say tumor's gone. Write me a Christmas card, maybe.
Yeah,
but sometimes that's not always possible, right? So,
yeah,
you want to preserve your facial nerve.
Yeah, another information about that is that when we call near total, very likely the radiologist will describe as a total resection. It's so, we know we left really just a paper of tumor on top of the nerve. So that's what we like to achieve, either a total or a near total. Subtotal, we use that strategy, but is rare and is really more in specific situations that we will just kind of leave something thick still on top of the facial nerve. And that it's case by case, comorbidity, other problems that the patient has. You want to get out of the table very quickly. Sometimes we have to consider those things. But I just want to mention what we were talking about earlier about the person with trigeminal neuralgia. I think in neurosurgery, our thoughts are out, like there is still a tumor. There is symptoms that are present there. And I exactly like, just want to emphasize what Josh mentioned, throwing radiation in these cases or just observation, for me, don't make any sense. It sounds like something needs to be done mechanically. Got to take that tumor out of there, even if it's a removal of the 2/3 of those 3 centimeter residual tumor, but more needs to be done to alleviate the symptoms. And then you can consider radiation once it's small. And again, if you're young, I forgot your age, then we would like to avoid even longer, like the radiation, as we mentioned earlier.
Yeah.
Dr. Prevedello, we're getting to the end of our time, but we're there. But I wanted to ask quickly, because there was somebody on the Facebook page that asked about retrosigmoid and that approach. They were told that leads to complete hearing loss. And so I wanted you to clarify
talk about
what the different types of surgery are and what the hearing results are.
Right. So very quickly, when I'll start with the retrosig, since you asked about that. Retrosigmoid is when we go behind the ear and we go around the cerebellum and reach the tumor. And most of the time we use that approach actually to preserve hearing. So those are medium-sized tumors that we would do, that we would, try our best to preserve hearing. And we've been getting, very good results with that, improving progressively on our hands. And we've been satisfied with that approach, actually. When we go translabyrinthine, we actually drill through the bone of hearing and we access tumors. For that, we do, doesn't matter the size of the tumor, we do that when the patient already lost hearing. In the middle fossa approach is when we go in front of the ear, and we use that approach for small tumors located inside the internal acoustic canal. And that we would do when we are trying, for the most part, to preserve hearing and facial function, and to remove those tumors coming from the front and from the top of the canal. And sometimes we get some surprises, just as to mention. Recently, we actually had one patient, and when we got down there, it was a facial schwannoma. So we have to be smart, identify the issue, And then because it's a small tumor, we will not attempt resection. So we just close, and that patient will be better served with radiation. And then there was another patient that we actually got down there. It was more related to a cochlear tumor. And then you have to make a decision, if you remove that tumor, you can lose hearing, but at the same time, patient is having a lot of problems with balance. It's better to take the tumor out and compromise hearing. So there's a lot of decision making during the process of surgery that can be very complex. But those are the three options we have. And sometimes just to finalize retrosigmoid approaches, we can combine with the translabyrinthine for those gigantic. Like I think we've done several now that the tumor is so large that we actually combine both. We go retrosig and translabyrinthine because at that point we're worried about the brainstem of the patient. Those patients have hydrocephalus; they are kind of dying of that tumor. So we associate that. And the other component is that the patient really has hydrocephalus. We sometimes have to associate the installation of a shunt to help these patients as well. We can talk more about that in another future discussion.
Yeah, there's maybe Melissa, let me say one
Go
thing.
ahead.
I think we always talk about the details of surgery, and obviously Dr. Wren, Dr. Prevedello, and I, and others. That's basically our daily business, right? I think it's very clear when you talk to people like Dr. Palmer that the same level of detail also applies to radio surgery. And I think being part of the team, and we're talking about the team, being just really critical. It's also critical that the radiation oncologist, that the team, that's part of the team, really understands the level of detail that is involved with managing these, right? I mean, the cochlear dose, some of the things that Dr. Palmer mentioned in his talk, right? That we rely on his expertise, obviously, to do that. But having the team discussion, and oftentimes, every time I talk to him, I learn something new about stereotactic radiosurgery, gamma knife or cyber knife, that's relevant. So I think it just always goes to show us that it's all about the details, right? And it's all about that multidisciplinary discussion that really we feel like really benefits the patient.
I agree. Thank you so much. I do want to thank you. I want to be mindful of your time and don't want to keep you too long. We are so grateful that you gave us this information and answered all of these questions. I want to let everyone know that I'm tracking all these questions. Any ones that we didn't get to, we'll try and figure out if there's a place for any of these questions in a future talk. We're going to be talking about hearing restoration tomorrow. We're going to be talking about facial issues on Wednesday, and the surgical and patient and provider experience on Thursday, and then balance on Friday. So I will take all these questions that we got on the Facebook page and here tonight and get those, try and put those into to one of those talks. But I do appreciate your time today, and tomorrow again we'll be joined by Dr. Hiss, who will join Dr. Wren and Dr. Adunka, and we'll talk about hearing rehabilitation. So we'll talk about that tomorrow at 4 p.m. Eastern, 1 p.m. Pacific. Thank you all so much. Appreciate you joining us.
Thanks for helping hosting us. Yeah. So.
We're happy to do it.
Thanks so much.
Thank you. See some of you tomorrow.
Appreciate it.
Bye.